Good afternoon, everyone. Thank you for joining us for the Future of Nursing 2020-2030 webinar on lifting barriers and designing better payment models. I'm Sue Hassmiller, Senior Scholar in Residence and Advisor to the President at the National Academy of Medicine on Nursing. The Future of Nursing 2020-2030 Charting a Path to Achieve Health Equity report released in early May and is currently available online. The report builds on progress nurses have made over the past decade. Since the last report on nursing, Leading Change, Advancing Health, we've strengthened education, advanced practice, promoted leadership, and increased workforce diversity. And I might add, we are still building capacity. We will not stop doing that. As the largest and most trusted segment of the healthcare workforce, nurses are well suited to help our country advance health equity. But nurses need more support from the systems that educate, pay, employ, and enable them to do this critical work. We have a great lineup of speakers today who will cover nursing practice barriers and how payment models can enable nurses to address the social determinants of health and health equity. So first, I'd like to introduce Dr. Jack Rowe, our first panelist, who served on the committee for the first Future of Nursing report. And the first report came out in 2010. He's a Julius B. Richmond Professor of Policy and Aging at the Mailman School of Public Health at Columbia University. Dr. Rowe will give an overview on the nursing scope of practice barriers. Dr. Rowe?
Thank you very much, Sue, and thank you all for joining us. As Sue mentioned, we have made substantial progress. And I'd like to focus on the specific issue of the scope of practice of nurses. The original Future of Nursing study, which was released in 2010 from what was then referred to as the Institute of Medicine, is now the National Academy of Medicine, had as one of its principal recommendations that nurses be permitted to practice to the top of their certification, licensure, and training. And that would imply that they would be able to prescribe medications, diagnose patients, provide treatments without the presence of a physician directly supervising them. At that time, the full scope of practice was available in 13 states and the District of Columbia, and it is currently available in 23 states and the District of Columbia. And in fact, Delaware recently passed a law to permit it, which is awaiting signature by the governor. So that would be 24 states. So we have made progress. We're only halfway there. And if you look at this map, and you can see in the blue, the states that have full scope of practice, you notice that a lot of them are those rectangular states, kind of upper in the upper left side. There aren't a lot of people in some of those states. So the actual proportion of the population which lives in states that have a full scope of practice permitted without restriction is well less than half. Now, a very important part of this dialogue has to do with the evidence. And when the Institute of Medicine reviewed over 500 papers 11 years ago, it was very clear that fully prepared and certified licensed nurses provided the same quality of primary care as primary care physicians. And that was really the basis of the recommendation for enhancing scope of practice. Since that time, the evidence has continued to grow. The scope of people living in states allowing for the full practice authority of nurse practitioners have significantly greater access to primary care, twice as much actually as people living in strictly restricted states. If all the states were allowed to have nurse practitioners practice the full extent of their graduate education, advanced training and certification, the number of U.S. residents who were living in a county with a primary care shortage would fall from 44 million to fewer than 13 million. After the Veterans Administration granted full practice authority to nurse practitioners in 2017, the wait time to see a provider fell from 16 days to 3 days. And in addition to access, there's clear evidence of quality as well, particularly the case with respect to maternity. Giving full scope of practice to nurse midwives significantly reduces costs and risks, as there are many fewer cesarean sections. Cost of care is also an important issue, and one of our colleagues, Peter Buerhaus, who was a member of the commission that offered this report, published a study in 2018 showing that the cost of care for Medicare beneficiaries was significantly lower if they were cared for by nurse practitioners than primary care physicians, even after you take into account or control for the difference in their individual compensation. So doctors are paid more than nurse practitioners. That's not the only reason the care is less expensive. In fact, the nurse practitioners order fewer imaging tests and get fewer referrals to specialists, et cetera. And there was a very significant savings at the national level for Medicare cost savings. Well over $40 billion could be saved. Now, interestingly, during the COVID pandemic period, 8 states temporarily lifted the practice barriers for nurses: Florida, Kentucky, Louisiana, New Jersey, New York, Tennessee, West Virginia, Wisconsin. And some of those are red states, some of those are blue states. So I named them for that reason. What's not really clear is whether or not that lift of the restrictions is going to be made permanent in any of these states. And we would hope that that would be the case. Reverting to the previous area of restriction would certainly be on the wrong side of history here and a step backward. And lastly, I just want to make one point. I think much of the data, many of the studies, a lot of the discourse has to do with nurse practitioners, advanced practice nurses. We're really talking about all nurses, all nurses. And if we can increase the scope of practice of all nurses to the level of their certification and graduate and education, that will be a tremendous asset to patients and their families. And this will particularly be the case in geriatric care. We all know that there's a tremendous shortfall of physicians trained in geriatric medicine. We also know over the next decade that there are going to be about 300,000 more nurse practitioners coming into the field. If we can get a significant number of those in the elder care workforce and capable practicing to the full extent of their capacity, then that will do a tremendous amount to alleviate the critical shortage we have in the elder care workforce. Thank you very much. Sue, over to you.
Okay. So thank you so much, Dr. Rowe. Really appreciate that. I want to encourage everyone at this time who's listening, almost 1,600 of you, by the way. I want to encourage you to put your questions in the chat function. We did ask for questions ahead of time from the field, and Dr. Rowe got to one of those. Dr. Rowe, you said that the Veterans Administration, through a policy implementation, is allowing all APRNs to practice to the top of their education and training if they are employed by the VA, no matter what state they live in. But unfortunately, every APRN except for nurse anesthetists. So thank you for getting to that question ahead of time. I want to now bring on Dr. Linda McCauley, Dean of the Nell Hodgson Woodruff School of Nursing at Emory University, who will discuss how to work towards lifting barriers for nurses in the primary care setting. And I might add, co-chair of an extraordinary report that came out at about the same time as our Future of Nursing report. Hers was on primary care, and she's anxious to tell you about that. Dr. McCauley?
So thank you, Sue. And hello to everyone who's listening today. And I have to tell you, one of the most exciting things is to be involved with the Implementing High Quality Primary Care report at the same time that the Future of Nursing report was coming out, and to have these two phenomenal reports kind of hitting the public at the same time and looking at the points of synergy. And that's what I want to focus on with you today, with particular emphasis on the future workforce and how the primary care committee approach the work around the future workforce. So next slide, please. So this report was very different from a lot of National Academy reports in that we were asked to build on a 1996 report on primary care and to actually address what had changed since 1996 and what were some of the barriers to implementation. And so the overarching theme was what's stopping us from making the changes, which I'm sure a lot of you in the audience ask that question all the time, like why, what's stopping us from expanded scope of practice for nurse practitioners? So the first thing we did was look at the definition in 1996, and there were changes that the committee felt were important to make. And this is the updated definition. And it is very whole person integrated care. It's accessible and it's equitable access. And it is provided by interprofessional teams. We avoided language around it's provided by a clinician, but now today we believe it's provided by interprofessional teams, and that you address the majority of an individual's health and wellness needs across multiple settings and through sustained relationships with patients, families, and communities. It should no longer be fragmented care. That it is we approached primary care as a common good, that it has high societal value, and it's highly valued, but it's in a precarious state. And we focused a lot on public policy around primary care, how we can provide oversight and actually monitor progress in this area. And nurses play a critical role in the provision of this common good that we call primary care. And as Jack mentioned, it is nurse practitioners, but it also involves all nurses that are part of this team, but that our focus really needs to be on strong advocacy, organized leadership, and public awareness. So next slide, please. So these are the 5 objectives for achieving high quality primary care that I think line up so well with the Future of Nursing report. 1, pay for primary care teams to care for people, not doctors to deliver services. There's clear resonance between these two reports there, that our reimbursement models need to be changed to reimburse all members of the team and not just to funnel all the payment through doctors to delivering services. Second, to ensure that high-quality primary care is available to every individual and family in every community. In 2019, 30 million Americans, non-elderly Americans, lacked health insurance. And 80 million individuals live in communities that have a primary care health professional shortage. And so we know that primary care is the only part of the healthcare system that results in longer lives and more equity. And so it is critically important that work towards primary care and work towards recognizing the contributions of nurses go hand in hand. The third recommendation was to train primary care teams where people live and work. This is a real challenge. I've already mentioned to you about these high shortage areas. So most of the care, most of the educational preparation of primary care team members take place in healthcare systems, academic health centers. How do we get them to the communities where people live and people work? And so that is critically important. And then the fourth objective is digital health. The 1996 report did not talk about digital health at all. So big change over the last few decades. And we know it is all now part of how interprofessional teams collaborate and work together. And then the fifth thing is, okay, how do we, if we know our goals and where we want to move, how do we get there? Next slide, please. So I pulled out some of the things, recommendations that are layered in the report. I think they're most relevant to the discussions we're having today is continued efforts to increase the supply of primary care clinicians. And that's certainly nurse practitioners. It's certainly other members of that core team. It is nurses who work in ambulatory primary care settings. It's all important. And we need to monitor this workforce, both the supply of and the requirements for these primary care clinicians. So do we have the data at our fingertips? We know we prepare a lot of primary care nurse practitioners, but are they all working in primary care, or do they get pulled into specialty care settings? Explore how to alleviate this geographic maldistribution. And there we go with the fourth one, amend the scope of practice limitations that Jack's already talked about. And also, how can we incentivize primary care services to support interprofessional education endeavors? We know there's a shortage of primary care training sites for our students, and it's a huge challenge to ask these sites to take interprofessional teams of students. These are major areas of focus that we need. And I have some other things to say, but I think they're going to be covered in our question and answer section. So I think I'll turn it over to the next speaker, Sue, if that's okay, so we can move through all this important content. Thank you.
Wonderful. So thank you. Thank you so much, Dr. McCauley. Our next speaker is Dr. Charmaine Lawson, a nurse practitioner from New Orleans, Louisiana, and the author of the children's book series, Nola the Nurse. Dr. Lawson will discuss the community perspective and how to work towards lifting barriers for nurses. And before you start, Dr. Lawson, I just really want to make a point midway through our presentations today that the Future of Nursing report, this last one, was really about nurses achieving health equity. So everything we're talking about here today would not be in the report if we didn't believe that that this all led to health equity in our country. Dr. Lawson?
Thanks, Susan. I appreciate it. Thank you, National Academy of Medicine, as well, for having me. What an honor to be here. I just want to shed a little bit about my practice and some of the practice barriers I have providing care, primary care here in New Orleans, Louisiana. I have the distinct honor of starting the very first nurse practitioner-owned house call practice in the state of Louisiana, and I'm still alive. Yes, I started this practice back in 2005, and as my luck would have me, that was the year of Hurricane Katrina. So my practice went through a lot of changes and unprecedented growth due to the storm, and I was able to successfully navigate it through the use of telehealth or an EHR. I was one of the early adopters, if you will, of an EHR for my practice, and was able to serve thousands of residents of Louisiana with primary care services and also with updated technology. Over the years, as most practices do, we go through changes, and here we are in a pandemic, 2021, and I seriously contemplated closing the practice after all those years because it was just tough dealing with barriers of having to get into having a definitely a continuous and more consistent collaborating physician, which I'll get into in a few minutes as far as the barriers. But not just that, it was just with the increased need to have resources to maintain a practice this large for so long, it was tough. So I contemplated closing the practice and moving to the East Coast, to the land of FPA, or as most of you will know, full practice authority, where I don't have to worry about any types of barriers for my practice. Well, let's just say I decided that maybe I should possibly stay and fight a little longer because I wanted to add behavioral health to my services. We offer primary care in the home. We have a very, very small clinic because most of our work is done in the home. And now we've moved into telehealth. Thank you, Corona, for getting us in a more acute way into telehealth and telemedicine. But now we're going to offer behavioral health because I just passed my Psych NP boards on Monday, and we're now going to be offering behavioral health services. So this is a good time to be in practice, but at the same time, most of my patients still don't get the health that they need in some of these areas because it's really just me. I have another NP who helps out maybe part-time, but for the most part, it's myself with all the services that we're getting ready to offer in almost all the rural areas. Now, there's still a physician shortage in the rural areas. And when I say shortage, I want to just further define that as physicians who will go into the home. Okay, so yes, there may be a slight shortage in the areas, but when you start to drill down a little more and say a physician or a healthcare provider, nurse practitioner, or a PA who is willing to go the extra level and see a patient who is homebound by all of the laws, meaning they can't walk or get out of the home without much assistance. So it becomes an issue providing care for them, and it's an issue getting physicians or healthcare providers who want to provide care to the vulnerable populations that I serve. So let's get into the barriers. Well, one of the first barriers is having to have a collaborating agreement in the first place. It's tough. We're working on it here. But we still have it, as do most states, have that antiquated law of needing to have a collaborating physician in order to practice. And I have, at several points in my career of having this private practice, have been faced with possibly needing to close the practice because I couldn't find a collaborating physician. And now that I'm double boarded in family practice and in psychiatry, I'm now tasked with always having to have not one, but two collaborating physicians, which is creating more of a bit more stress, but it's something that I have to deal with. This is the red state. This is a collaborative state, right? So that's a major barrier for my practice, and definitely is a barrier to health equity for all of the residents that I see who are truly homebound and in many cases bedbound. I address the laws and I address the physician shortages, but let's talk about the fees that nurse practitioners have to pay to collaborate. This is not free. We have to pay physicians for their services. And so, as I said earlier, with me now adding the other specialty of psychiatry, I now have to employ 2 physicians to work with me in my practice because of the collaborative agreement restrictions in the state of Louisiana. And this is the biggest issue I have and is the biggest barrier to health equity for the residents of Louisiana that I serve. I could say so much more, but I don't think I have the time today. So, Sue, I'll turn it back over to you. Thank you all for having me.
Thank you, Charmaine. Thank you so much. Nothing like a frontline provider, right? Love having you, Dr. Lawson. I just want to clarify too, we'll get to the Q&As later, but I know you mentioned that collaboration is a barrier. And I think to clarify, I know you and you collaborate very well with physicians all over the state of Louisiana and New Orleans. It's the financial barrier that is put upon you through a contract is what you're talking about. Absolutely. as a challenge, right? Yeah, I know you're a big collaborator.
The contract necessitating that I collaborate, because we are going to collaborate. We all believe in, of course, team-based care. That's definitely, the standard for advanced practice nursing. But having to have a contract stating that you're unable to practice unless you have this contract is a barrier, and it's becoming an unnecessary expense that in some cases, if I can't afford it, that means that I may have to close my practice, and then it is a barrier because those patients who are on that panel won't get care.
Yeah. So we're going to move on, but I know a lot of people don't realize that APRNs, all APRNs, right, advanced practice registered nurses, nurse anesthetists, midwives, and nurse practitioners, and I would imagine some clinical nurse specialists really do have to pay either out of their own pockets or their employers' pockets to really have these contracts. Correct. So I think that was an educational point today. Thank you. Thank you. So our next speaker, like Dr. Rowe, was also on the committee on the future of nursing, our second report here. And he is the Richard Perillo Family Professor of Healthcare Ethics at the Department of Health at the University of Chicago. And Dr. Chin will provide an overview of effective care management programs and payment models. Dr. Chin, is it all about the money?
Well, partly, Sue. Money is an important driver of behavior. So next slide. This slide shows the conceptual model from the Future of Nursing report. I want to highlight a couple key factors. So start with the green bar towards the top, nursing roles. So nurses are central. And you see right below that nurses in a variety of roles impact determinants of health. These are both medical and social determinants at individual and structural levels. For example, a nurse might be taking care of a patient with diabetes and helping that individual with their insulin management. That nurse could also be part of a team creating a system of care that provides the best holistic care. And simultaneously, that nurse might be addressing a patient's social needs, such as a patient's food insecurity, and that nurse might be part in an overall partnership with community-based organizations to address the problem of food insecurity in the community. So it's medical and social determinants of health at individual and structural levels. And at the bottom there, you really see the North Star. And I think this has been a theme through all the presenters so far, that what drove the report really is a report really about the public and people. And nurses, a nursing report, but really North Star is improving individual and population health. And as Sue said, improving health equity and healthcare equity. And so if that is the North Star, then it's easy to connect the dots that to get overall great population health and healthcare equity, we need to address holistically medical and social factors. And there's a robust evidence base then of the key role for nurses in addressing those medical and social factors effectively to improve equity and to improve overall individual and population health. Next slide. So regarding effective care models, there's a lot of evidence regarding the effectiveness of nurse care management and team-based care, both for overall population health and for advancing health equity, transitional care teams being one example. What these all have in common are that these models address the medical and social needs of patients. They involve close monitoring and follow-up of patients. There's true listening to patients and families, establishing relationships and trust, and it's adequate time for nurses to do this. And when you poll patients and families, this is what they want. They want to be listened to. They want to have trusting relationships. They want to be respected. They want to be viewed as whole individuals with their medical and social needs addressed. And as others have talked about, expanded scope of practice and telehealth. Next slide. Here's an example we cite in our report, the Care Oregon Medicaid Plan C-Train Transitional Care Model. This works with patients from hospital discharge to 30 days post-discharge. It involved team-based care with an RN and a social worker. These personnel help the patient navigate the health system. They reconcile medications, a key issue in terms of the complexity of medication lists in the outpatient and inpatient setting that may differ and need to be reconciled. The nurses coach patients about health. They educate. They identify social needs such as food insecurity, homelessness, insufficient housing and clothing, and establish relationships as well as link to primary care specialists and behavioral health. So again, you see that link to the conceptual model diagram. Next slide. So here is the recommendation on paying for nursing care from the report. On the left, federal, tribal, state, local, and private payers and public health agencies should establish sustainable and flexible payment mechanisms to support nurses in both healthcare and public health, including school nurses, in addressing social needs, social determinants of health, and health equity. Note that it's both public and private payers. It's sustainable. So this is not like these one-off funding programs, but the base core funding system. Flexible. They're going to be different contexts. So these types of payment mechanisms need to be flexible to allow different organizations and plans to best serve their populations. It's healthcare, public health, including school nursing. And again, as Sue mentioned, the heavy emphasis upon addressing social terms of health and advancing health equity. In my remaining slides, I'll address most of the areas on the right-hand bullets. Next slide. So fee-for-service, which I think most people would agree is basically an inefficient, lousy system where we pay for each individual billed service. So we're incentivizing volume. This was the first bullet in Linda's slide about the high-quality primary care report. And so we have a number of recommendations. So as we start to transition to more logical systems, there still will be a period of time where we have a lot of fee-for-service. And there are things we can do to improve fee-for-service in terms of these issues. So first, include current procedure terminology codes for nurse-led services and fairly reimburse these services, such as case management, care coordination, team-based care. We heard from Charmaine the crucial role of nurses in behavioral health, addictions, social terms of health, and health equity. Reimbursing for school nursing, and as Jack and others talked about, enabling nurses to bill for telehealth. Next slide. So we're seeing the shift from fee-for-service to value-based payment and alternative payment models. Here we're defining value-based payment as those models that reward paying for quality and value, value being a metric that incorporates both outcomes and costs. So the recommendations for the report really focus upon advancing health equity and addressing social terms of health, and then that linkage to why nurses are crucial for those particular issues. So we recommend using clinical performance measures stratified by risk factors like race, ethnicity, and socioeconomic status. Support nursing interventions by incentivizing reductions in health disparities, improvements in care and outcomes for at-risk populations, high quality care for at-risk populations. So for example, nurse-led care management models, again, has a robust literature showing how these can be used for these purposes to advance health equity. And then third, incorporate disparity-sensitive measures that support nursing interventions that advance health equity, such as process measures for need-based care or outcomes such as preventing avoidable hospitalizations. Next slide. Alternative payment models. These are models that promote value and cost efficiency. Organizations take on financial risk to deliver high-quality care at lower cost. An example are accountable care organizations, or ACOs, which are responsible for the health and costs of a predetermined population of patients. So we recommend that these models provide flexible funding, such as capitated payments, global budgets, shared savings, per member per month payments, accountable health communities models for nursing and infrastructure that address social determinants of health. So, for example, some plans have for all the beneficiaries a model where there is a fee paid to providers or health plans per member per month, they say, that can then be used to support these type of team-based care models, for example, or community health workers, or this nursing infrastructure that can successfully address social determinants of health. Third bullet is we recommend incorporating value-based payment metrics that enable nurses to address social determinants of health and advance health equity. Next slide. Finally, school and public health nursing is a very important part of our overall healthcare system and grossly neglected overall in terms of attention and funding. So we recommend allowing school nurses to bill Medicaid. We recommend financing public health to address social determinants of health with funding streams from multiple public and private partners. Align incentives to address social determinants of health and advance health equity across health, public health, and social sectors. Leverage the nonprofit hospital community benefit requirement that nonprofit hospitals have to serve the community. Many of these, if done appropriately, could successfully address social determinants of health, advance health equity, and involve nurses in key leadership roles. And then make pay scales for public health nurses competitive. Equal pay for the same services provided. Thank you very much.
Oh, thank you very much, Dr. Chin. So our next speaker is Dr. Ellen Marie Whalen, who is the Chief Population Health Officer at the Center for Medicaid and CHIP Services and Senior Advisor for the Center for Medicare and Medicaid Innovation, and she'll discuss designing better payment models as it relates to social determinants and health equity. And I might add that even though Dr. Whalen was not on this committee, I will tell you that she is always helpful to the National Academy of Medicine in every way, shape, and form, and really served as a very valued colleague and consultant to me as I was the study director for the first Future of Nursing report. So thank you for that, Dr. Whalen, and take it away.
Thank you, Susan, and thank you for inviting me to be on this panel, and also for inviting me to participate at times in some of the work that you're doing through the Future of Nursing. So today I want to talk about designing better payment models that will maximize, we hope will maximize nurses' contribution to healthcare in order to improve the health of the nation, as well as looking for ways to help address equity. And I guess I'll just note first that here I am sitting at CMS, and as a nurse and a nurse practitioner, I never imagined I would be working on payment policy. But I'll just note a couple of the issues that happened during my clinical work that helped direct me to think that maybe this is something that I wanted to do, work in the federal government in payment policy, especially because it relates to some of the barriers that nurses are having in fully contributing to the healthcare system. The first is there were clinics that I was working in, and in one place I couldn't even sign my own prescription. This was in Pennsylvania in the late 80s and early 90s. Yet in other clinics, I was able to dispense the medication directly to the patient. And that was in part because of certain federal policies that were paying the clinics different ways. So in one place, I couldn't even sign my own prescription. In the other place, I could actually dispense the medication. And the second is similar to Charmaine's story. I was able to start an adolescent primary care clinic in a community center in West Philadelphia in the mid-90s, in part because of federal payment policy that allowed direct reimbursement to nurse practitioners. I was one of the first Medicaid, one of the first nurses to be able to get direct Medicaid reimbursement. But the process that I went through and the things that were coming up as we tried to do this made me think, who's making these policies, and is there a way that I can contribute to that? And so here I am, though I miss clinical practice, I'm thrilled to be able to be looking at some of these issues from the federal policy level. So to follow what Dr. Chen just talked about, I'm going to talk about moving away from fee-for-service into alternative payment models or value-based care. And I won't go into many of the problems with this fee-for-service. I'm sure everyone who's watching better understands some of the issues that are happening. But fee-for-service, we're paying for individual services over and over again. And there was never an eye in payment policy, never an eye to improve health equity or health outcomes or improve care delivery. It really was looking to just pay for the services delivered. And of course, because of that, we got more services delivered and not necessarily improved patient outcomes. So as we now at CMS, both in CMS Medicaid as well as the innovation centers, we're looking to design new alternative payment models, new care delivery models. I want to just mention three things that I think by three issues that we can address through the movement from fee-for-service to value-based care. The first is actually having payment models help change the care delivery model. And I think that's really important. We're not doing new alternative payment models just to come up with a new way of paying. What we're trying to do is look to see what's not working now in the care delivery model and how do we create a payment model that supports the care delivery model that we think will improve outcomes. And of course, as we're looking to see what kind of a care delivery model improves outcomes, the role of the nurse is critical there. And it's not just the role of the nurse, it's the role of the entire health clinical team, the whole health team, including some non-clinical providers. And fee-for-service tended to pay individual services, mostly to physicians, for the service they delivered without an eye towards that improved outcome. This now is looking to pay clinicians, clinician practices, health systems, based on the outcomes that the patients are having. Better payment if the patient outcomes are better, less payment if the patient outcomes are not better. And I was thinking about when I was working in the United States Senate in the early 2000s, it was a kind of a novel idea that a new payment policy was announced that was no longer going to pay for a list of never events, including things like amputating the wrong leg. So before that, someone went in to get a leg amputation. The right leg was supposed to be amputated. The left leg got amputated. The patient, the clinician still got paid. So that was early on. We're being much more deliberate now, thinking, what are the outcome measures we're looking for? How do we pay for care that will support this new care delivery model? And I will just note the first objective to the primary care report that we just heard presented. And I'm really thrilled that the very first outcome there is, or objective there, is to pay primary care teams to care for people, not doctors to deliver service. And that's really what we're all about there. So looking to see how we can maximize the contribution of everyone in the healthcare team to be able to provide better care to improve patient outcomes. The second thing that we are thinking about as we're designing new care delivery models is how we can better address social determinants of health. We all know, you've all seen the slides, most of what keeps us healthy or makes us sick does not happen in the healthcare delivery system, not in the 15 minutes that you spend in a physician's office or any clinical office once a month. So in Medicaid is thought of as not just an insurer, but a medical assistance program. And so in Medicaid, we're looking to see how we can maximize the flexibilities that states have to address things like transportation. In some parts, some housing issues. We look to see how we can keep people in their home and not have them move to an institution. That's a housing issue. That's a social determinant issue. CMS Medicaid released a letter just in January of this year, alerting states and reminding them of all the things that they have within their existing toolkits that they could be doing to better address the social determinants of health. So that can't happen necessarily in a fee-for-service system. We are much more able to look at those issues and look for ways of supporting payment models that allows those issues to be addressed in value-based care in new alternative payment models. And the last thing I'll mention, because it's an important part of this Future of Nursing report, is how we can achieve health equity. Tough nut to crack, right? Health equity is something that we've been dealing with in the United States for decades. We know that the infant mortality rate, for example, is much higher in people of color than it is for Caucasians. And we've not moved the needle on that for a long time. So this administration is really spending a lot of time trying to think about what we can do as we design new payment models, new care delivery models. What can we be doing to make sure that we address equity issues? one of the very first executive orders that President Biden signed when he came into office, actually signed on Inauguration Day, was an executive order on advancing racial equity and support for underserved communities through the federal government. And so we are taking a whole of government approach. We're working not just within CMS and the different agencies there, but we're working with HRSA. We're working with CDC. We're looking to see what we can be doing if we work together to be able to address this within the federal government. But I'll also note that we are working outside the federal government. We know that CMS can't do this alone. We have to be working with the private payers. And so a number of years ago, as CMS started the advancement away from fee-for-service to alternative payment models, we started working with the private payers. We wanted them to get on board and say, not only would we be looking to make this movement, but we were looking to see if they would make a commitment to move from fee-for-service into more value-based care. We are now looking to do something similar to address equity. And I will note that there's an entity that was created called the Healthcare Payment Learning and Action Network, which we affectionately call the LAN. They have been looking to bring the public and the private sectors together to look at moving away from fee-for-service. And we have just created, as part of that, the Health Equity Advisory Team, HEAT. And I will say that it is co-chaired by our very own Dr. Chen that just presented right before me, with a nurse co-chair. And I'm on that committee with a bunch of there's about 3 other nurses on that committee as well. And what we are doing is looking to see what can we be doing as clinicians, as health systems are looking to want to address health equity. It's not an easy nut to crack. So we are coming together to look to see what is it that we can be doing? What are we measuring? What are we tracking? What are outcomes we're looking for? What is it that we can do in the primary care space, in the broader healthcare delivery space, to be able to look to addressing equity issues? Equity is not the same care for everybody. It's those that need more get more. And how is it that we can do that in a way that not only we can do it within CMS, but also that we can work with our partners on in the private sector to be able to do that as well. So the 3 things that I think is most exciting, especially in terms of what is being promoted and recommended in this report, is moving towards having payment models create a new care delivery model that maximizes the entire healthcare delivery team, including nurses and not just NPs. I think RNs in primary care are another huge benefit that we can figure out how to do a better job there. The second is how we can use payment models to better support the addressing social determinants of health. And last, how we can do a better job looking at trying to address equity. Another thing that I'll flag, and maybe we'll have time in the question and answers, is if we're paying for outcomes, we have to know which outcomes we're paying for. So that measurement, what are we measuring there? Are there measures that nurses can help address? So if we're paying for certain outcomes, we have to make sure that we get those outcomes right. But I'll stop there and turn it over because I think we're going to have a really robust question and answer period now.
So thank you. Thank you so much, Dr. Whalen. I really appreciate your time. And we're going to get to our questions now. We're going to have a panel discussion. So let's stay on this payment issue for a little bit longer, shall we? Let me go back to Dr. Chen, and then I'm going to have see if you might want to elaborate, Dr. Whalen, and talk about your measuring outcomes as well. I know that that is a cliffhanger for us. I realize that. So, Dr. Chen, where should we start regarding the payment recommendation? Where should we start regarding the payment recommendations? And if you and Ellen Marie can take that on, I would appreciate it.
Well, thanks, Sue. And I'm actually going to build upon Ellen Marie's comments, which I agree with. And in some ways, like do the next level of detailed dive. I think the first priority is to really be intentional about our goals. Now, right now, as we say on that conceptual model slide, the goals should be improving individual and population health. It should be advancing health equity. It should be holistically addressing the medical and social factors that affect a patient's care. It should be improving patient and family experience. If that were so, then there would be an incentive then for organizations to do this type of work. The problem is that despite all the rhetoric by all types of parties saying we value equity, we value patient experience, we value social terms of health, there's unfortunately little concretely baked into our payment systems that actually create the incentives so that our healthcare system is truly geared towards improving patient outcomes, patient experience, advancing health equity. So, for example, the various clinical performance measures that, frankly, public and private payers use to reimburse providers and value-based payment systems, again, do little for incentivizing, addressing social determinants of health, or addressing a patient's holistic needs, or advancing health equity. And so, as Ellen Marie said, the key is not payment reform for payment reform's sake, but payment reform that will support and incentivize the types of care delivery systems that can reach those outcomes we need. And we know from the evidence base, there's just robust evidence for nurses playing a key role in all those factors: advancing health equity, addressing social determinants of health, respectful relationship with patients, trust. So these are all things where if we are intentional about our North Star goals of patient outcomes and equity, and continuously link the evidence base for how nurses are critical for reaching those goals, and we create the metrics and financial systems that reward and incentivize this, that's the way to get there.
Dr. Whalen?
Yeah, well, and I'll just follow up on the importance of nursing in there, which I didn't focus on as much. I think to Marshall's point that it is the care delivery model. And for example, I was coordinating a learning collaborative with pediatric awardees at the Innovation Center who were serving kids with medical complexity. And the intervention across the board was not a new clinical issue. It was not a new medication. It was how to better coordinate care. Every single one of them came, and the model that they wanted to promote was how to do a better job coordinating care. And I think that's common across all of our payment models, whether it's primary care specific or whether it's broad. And that is what nurses do, right? That's the bread and butter of what nurses are doing and helping to coordinate that across. So that really is, I think, part of what we want a payment model to support. In terms of measurement, if we are paying based on what outcomes, we have to make sure that those outcomes are something that is affected by the intervention. Sometimes it's easy to say we have a measure, so therefore we'll use it. But is it something that we really can move the needle on? I think a lot of nurses are doing some research on what quality measures should be used. Should they be used in payment? Should they be used just to monitor? Should they be used for research? And differentiating that is going to be really important in the future, because if we are saying that certain payments will be made based on certain outcomes being improved, we want to make sure it's an outcome that really tracks a transformation of the care delivery model. Some outcomes are easy to pull a bus up and immunize folks, right? That doesn't necessarily show that we've transformed the care delivery model, but we want to look for getting those outcomes right. And that's going to be, I think, a challenge and an opportunity in the future.
Thank you. So I want to harken back now to the scope of practice barriers. I think Dr. Rowe, Dr. Lawson, Dr. McCauley all talked about what the barriers were. We had a lot of questions come in online ahead of this webinar asking for tips on how to get those scope of practice laws modernized or authorized, if you will. Dr. Rowe, we can start with you. You're a prominent physician and a healthcare administrator. We know that's some of the issues. What tips do you have for allowing modernization of the scope of practice laws? What tips do you have?
Well, I think that we have to recognize that the resistance to modernization largely comes from subsets of organized medicine, and but not all parts of organized medicine. So, for instance, the American College of Physicians, which is, I think, actually got more members than the American Medical Association, has been strongly supportive of the recommendations of the 2010 Commission report. And so one of the things that I think is important is to identify and collaborate with elements of medicine physicians and physician organizations and local physician champions in states that are very respected. It might be the CEO of a hospital who happens to be a physician, or a very respected. Now, if this was 20 years ago in Texas and Mike DeBakey said he thought we should do this, the Texas Senate would listen to him, right? So, I think that's one tip that I would give. I think there's another side of the coin. I don't know if you want to address this now or later or not at all, and that is, it's not just limitations to scope of practice at the regulatory level. There are limitations to scope of practice at the institutional level within hospitals and health systems. And that calls for a different strategy. I don't know do you want to talk about that for a minute?
Absolutely.
Okay.
You were the top administrator at Mount Sinai. I think you're authorized to talk about this.
Okay. I survived 12 years as the president of the Mount Sinai School of Medicine and the CEO of the Mount Sinai Health System in New York, which was one of the largest in the country. So here are the lessons I learned: how to get something like this done, or some other things that we would try to do. The first is you need to throw a lot of process at this, and it has to be inclusive. And it has to have a committee or a group that is led by a clinical champion. Okay. So when I tried to do something not exactly this, but something akin to this, I didn't chair the committee myself. I didn't have one of my vice presidents chair it, even though they may have been a nurse or a physician. I had the chairman of surgery chair it. Okay. So you need a clinical champion who's respected. The second is you need to start with a specific area. Don't try to do the entire institution at once. You're picking too many enemies. Pick an area that's susceptible to this, where the leadership of the area is interested in it. So like the emergency room, or pediatrics, or the psych unit, or the geriatric care unit. Pick a specific area that is susceptible, interested, and show that it can work. Number three, which is number 3, 4, 5, and 6, actually, is show the evidence. This is not politics. This is science. Okay? Lead with the evidence. Show that committee the evidence. Get that committee to share the evidence in different kinds of settings and town hall meetings. And then lastly, if you can arrange it, find somebody on the board of trustees who's susceptible to this and can be a champion at the governance level. That makes a huge difference. And maybe even if you're really lucky, somebody on the board of trustees who's a nurse. But if not that, somebody who's got a spouse who's a nurse or a child who's a nurse.
Now there's an idea, a nurse on a board.
Okay, so I'll quit there.
That's great. Thank you, Dr. Rowe. So Dr. Lawson, staying on this topic a bit, and the local level, Dr. Rowe talked about a health administrator level, and you've been working in New Orleans and Louisiana to really create modernization in your state. Can you give the rest of the listening audience some tips for how to talk to, how to make this happen, and including how to talk to legislators? How important are stories, for example?
Right. Well, on a local level, I think for someone like me who has a small, to me, in my eyes, small practice, private practice, one small way a hospital can help is by allowing nurse practitioners to admit their patients to the hospital, by allowing us to have privileges at the hospital where we can admit our patients and where we can actually follow them and see them after being admitted. Right now, there's a barrier there. Some hospitals will not allow me to admit my patients there unless my collaborating physician, has privileges on staff. And so that means he has to get privileges at every hospital before I can admit certain patients there, or we have to do another route and hire a hospitalist team to admit our patients. So it's tough. So I would say that's a small barrier that I think would be very helpful to a lot of patients who have to wait to be admitted to a hospital system because my collaborator or other NPs who are in practice for themselves, their collaborators are not on staff at that specific hospital. So that would be a big help. I can't hear you.
Dr. McCauley, I'm going to turn it over to you. I want to ask you, I know you've been working hard in Georgia, where you reside, and with the Georgia Action Coalition and your colleagues in Georgia around APRN modernization laws. So can you give any tips for, what works? How do you get this done? What works with legislators? What works with anybody you've been talking to? Give us your tips. You're on mute. So start from the beginning.
So I think, as Jack described, this is multifaceted, and there are many roads we can take to get to the end result, whether it is working with our professional organizations, our state legislatures, and I don't think Georgia is an example to hold up to the rest of the country, but and healthcare systems. What I learned from doing the primary care work is that we can't exclude the federal government. And if you look at what the Veterans Administration was able to do in terms of expanding the scope of practice, it's just phenomenal, because there's going to be a lot that we will learn from that process to use elsewhere. But what the primary care committee recommended is that, and it's around primary care, but I don't think that's a bad thing, because I think if you look at how many nurses are involved in primary care, ambulatory care, public health, it's important, is that at the federal level, there is not one accountable party. And so if you have a fragmented system of accountability, you will have a fragmented system of implementation. And we are having very high level discussions about whether this should be an office in the department, DHHS, or how this should be organized so that we have one collective voice. And if we could get a collective voice for primary care and how to deliver team-based care and health equity, it would be extremely powerful. We don't even have that now. And so that's, I think, something I can add to this discussion of another stakeholder that's critically important, along with those that were described by Dr. Larson and Jack. And so thanks for that question. It's a lot of work, multiple areas.
Yeah, thanks. Yeah, I want to invite all the panelists, no matter what question I have or who I might direct it to. If you want to add something, please just, go like this, give me the wave, and let's make this a real discussion. I want to ask everybody, but let's start with Linda, Elmarie, and Dr. Lawson, Charmaine. Jack, you mentioned that it'd be helpful to have a nurse on a board, right, as one of your tips. So how do we get more nurses on boards? Coming from a nursing perspective, what do we do? How do we get nurses on boards? And there was a question that came in and said, how do we get more nurses to run for office? So these are kind of related. So how about we have the nurses tackle this one, and then we'll harken back to the physicians.
I think I want to go first and take a stab at this.
Okay.
For me, particularly the board, question, how do we get on boards? Well, then I have a question. How do we? Who do we talk to? Do we just contact a board, a hospital that we're interested in, a vendor, a big group? I'm just going to name it Amazon, Target, and say, hey, here's my CV. I have X, Y, and Z experience. Do we hire an outside group? I've spoken with an outside group. I don't want to say the name, but there's a group that I've spoken to, and you pay them a fee, and they take your CV and they will disperse it to several, entities and boards. How do you, is that the right way? There's really no blueprint on how to do it. I think I'm not alone in my desire to be on boards and to run for a political office as a nurse.
All right.
You want to do it, but how? Is there a blueprint?
So Dr. Rowe's going to weigh in here because he has a way in, perhaps.
He does? I need your phone number.
Yeah. So can you hear? I lost the feed for a minute. So can you hear me?
Yes, you're good.
Okay.
You're good.
I think there are a couple different approaches, but one very important, valuable approach is to simply go to the executive search firms that populate the boards of hospitals and health systems and talk to those executive firms, give them your resume. And when they are looking for board members for a health system or a hospital, they are talking with the executives at the health system, and they can mention, look, we have this doctorally prepared nurse who's the dean of a school, et cetera, et cetera. The other way is to talk to people who are on boards. So I will give you a specific example. I recently left the board of a very, 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 very large healthcare company that owns over 200 hospitals in the United States and other countries. I won't mention the name of that company, but it's a very big company. I was a clinician on the board, and I left the board after many years. And I said to the CEO, I think you should replace me with a nurse. And here are a couple nurses who are deans of elite schools. And why don't you interview them? And they interviewed a couple and they put one of them on the board. There you go.
Yeah. So
that's not, we didn't get a nurse on a hospital board doing that. We got a nurse on 200 hospital boards doing that.
Great. Thanks,
So,
Jeff. Oh, sorry.
So, I think that's another approach is talk to people who are on boards who might be sympathetic and have them talk to the chairman of the board. And now not every hospital uses these search firms, right? At Mount Sinai, we had no shortage of people who wanted to be on the board, right? So that was, it's not like we had to go looking for people, but many hospitals are looking to fill diversity, inclusion related slots, and I consider this part of the diversity and inclusion.
So thank you very much. The one thing I wanted to mention before calling on Dr. McCauley and Dr. Whalen is that a number of years ago, the nursing community knew this was an issue. So some of us started an organization called Nurses on Boards Coalition, and nobc.org, Nurses on Boards Coalition.org. And they are an organization who will help with this. So Dr. McCauley, Dr. Whalen, How do you get nurses? We've talked about nurses on boards, but if you want to add on to this, and Dr. Whalen, I heard that you did a lot of work on the Hill. How do we get nurses on the Hill and working in public office? I'll call on you in a minute. Go ahead, Dr. McCauley.
So I think as an educator, I think I have to own some responsibility with this. And I think historically, we all recognize it's important to have the nursing lens on boards. That is truly important. But the nurse that's on a board has to broaden her lens, his or her lens. And when you're on the board, you have to be able to opine on things other than nursing. And that might be being a huge advocate for social determinants of health and vulnerable populations. It might mean understanding reimbursement models as well as the physician sitting next to you. It may mean understanding laws and policies that affect practice, as well as the attorney sitting next to you. And from my experience, we need to start when a person enters nursing to, in addition to focusing on practice competencies, we need to get serious about this area of policy and how you begin to introduce at the youngest age that policy is different than advocacy, that our curriculum needs to talk about the laws that impact whether people can pay for their medications. Every student ought to be able to tell us, recite that map that Jack showed in terms of scope of practice. We just don't spend enough time. And I would say medicine also could do a lot more in this area. I had a MD, MPH student once say to me, I had to go to a school of public health to get an MPH to understand the industry that I was entering into to practice for the rest of my life, because his medicine education was so focused on the care of patients and not that broader lens. So I'm hoping with the new nursing essentials and competencies, we'll get serious about this, because you can't just decide at the age of 40 you want to be on a board if you haven't been inquisitive about these larger issues all along. So,
right. Thank you. So, Dr. Whalen, you have a very prominent position as a nurse, as a policy expert. So how'd you get to where you got to, and how do other nurses do it and run for office and be on the Hill?
Thank you, Sue. And I completely agree with Dr. McCauley that I think having nurses teaching them about policy, but also understand how policies are affecting their practice is a really important thing. And I was going to talk about, it's not just nurses on boards, but it's nurses at the right tables. And there's a lot of tables out there where we need to be represented. And there's a saying here in DC that if you're not at the table, you're on the menu. And so being at those tables is a really important step. And there's all sorts of places that you can see. One of them, as we're talking about alternative payment models, many of the payment models have a shared savings model. So some of the payments come back to healthcare systems based on how well they do on outcomes. Well, when those savings come back to the institution, how do the savings get distributed to which departments? Who's making those decisions? So I guess one of the things is, what are the policies that that nurses are seeing that are affecting their practice? I talked a little bit before about starting my own practice, and I was frustrated I couldn't sign my own prescription, but there was someplace else I could distribute medications, getting reimbursed. Whether or not getting into, I was a fee-for-service provider, but I could only get into one managed care plan. So what are those policies that are hindering you maximizing your contribution? Is it working with kids and better understanding about WIC? Is it better understanding your public health department, and maybe in the academic setting, having students do independent studies with some policymakers at all sorts of different levels? I was fortunate to have a Robert Wood Johnson Health Policy Fellowship that brought me to Capitol Hill. I ended up staying in the Senate for 5 years, better understanding. This was after I had a degree in policy, but that's a wonderful opportunity for clinicians to really get embedded into mostly Congress, but also in the administration. I have a student working with me now as a fellow because I'm trying to have students better understand what policy means. And I was thrilled to see that I think as part of the curriculum for the Doctor of Nursing practice, that policy is a big piece of that. And I think one thing that we could do there is not having every faculty member that's teaching in the DNP program to have to create their own curriculum. Maybe there's some way that we can help that and try to make that a little bit more prominent.
Okay, so thank you. I want to get to a couple of other questions around payment now. And let me see, I want to ask, let me ask Marshall and Ellen Marie, and then Jack can weigh in too. What is the industry appetite for a payment model recognizing and embracing nursing practice? What's the industry appetite for this?
I'll frame it more widely in terms of like the industry shift from a fee-for-service model to value-based payment, alternative payment models, and then more recently, interest in social terms of health and health equity. I personally have not seen a lot where the industry is specifically focusing upon new nursing models outside of that particular element of this new horizon now of this really sort of shaking the system up. And there, I think, again, like the key is that like even like 3 years ago, I don't think much of this was on the radar screen, whereas it's evolved so quickly that I think like now it's like the same discussions I'm seeing in a variety of different arenas where there's now, I think, fairly uniform agreement that, well, social determinants are important, equity is important. So there's like a lot of well-meaning intent. You get a lot of organizations and associations struggling with, well, how do we actually make this concrete? So I think we're in a stage of evolution where now the will is there. Now we've got to get concrete regarding how we operationalize. I do think, though, if we keep the North Star of population health outcomes, advancing health equity, holistically addressing medical and social needs, nurses will do well in terms of they're just so crucial, as people have mentioned throughout, of the skill set, the expertise, the evidence base of just doing so well with that. So if those are the North Stars, nurses will be very integral in all these discussions.
Right. Dr. Whalen, yeah. Go ahead. Or Jack, did you want to chime in? Go ahead.
Yeah, I would add an additional perspective. I agree with what Marshall said. For the industry, when you say, what does the industry think about including payments for nurses? From the point of view of the health insurance industry, there are some small companies that are emerging, startups. They're very wary of getting on the wrong side of the medical associations. They don't want to get locked out by the state medical society, telling all its members, you know, that such and such company is doing such and such with nurses, and we don't think that's right, et cetera, et cetera. So there's a little politics there. But for the bigger companies, that's not so much of a problem. Particularly in states which are not restricted, have full practice authority, because they have big enough market share that the physicians aren't going to walk away. So I had, when I was the CEO at Aetna, I had maybe 23, 24 million customers. It's a lot of customers. And if you took the Fortune 100 companies, 86 of them were my customers. That was my business, self-insured, large customer. The employers like it, number one, but you have to work with the employers. You have to make sure that the employers understand it and like it, and the employers don't think that you're trying to give their workers and beneficiaries second-class care. So I would spend a lot of time educating my customers who were my employers about the evidence. It always comes back to the evidence. Mm-hmm. And The other thing that I would tell them, which is really important, is, as I mentioned it in my initial remarks, Peter Burehouse paper in 2018, but there are other papers before that. It's less expensive. It's going to reduce their expenses. If they're self-insured employers, because the nurses don't order as many MRIs, they don't do as many biopsies, they're not, and so on and so on. And they're going to save money. So if medical costs are an issue for employers, which they are for essentially all employers, it's an important part of their budget, they're going to save money. So you give them the evidence and you give them the economics, and you focus on the employer. And that would be my strategy.
Okay. So, Dr. Whalen, I'm going to ask you, but I'm going to put a secondary question into your little hat here as well. So the question came through, how can we create equal opportunities for RNs? For example, nutritionists can bill for diabetes self-management education using telehealth, but RNs, CDEs could not. So there's a temporary override of this during the PHE, but this is unacceptable. RNs in primary care. So, Dr. Whalen.
Thank you. I think that question reinforces why we need to move away from fee-for-service to value-based care, because it's random sometimes who gets paid for which services and why. And I think if we're looking to improve patient outcomes, then looking at that total cost of care model where we don't bill individual clinicians don't get paid on the service, we look to see what the outcomes are. So I would say that it isn't fair. There are some changes that we made during COVID. Some of them we think will stay. But I think it reinforces why the fee-for-service system is broken. And when we talked about the industry, it's interesting, what I was going to talk about before Dr. Rowe was the purchaser of the healthcare is critical. Who is that purchaser? And as Dr. Rowe said, the employer who is invoking the insurer to kind of manage that, but they are the ones purchasing the insurance for the patient. In Medicaid, it's the state. The state is purchasing that health care. And if we look to them, the original question was, how do we move along this continuum and get in? Does industry want to move towards value-based care? The answer is yes. If the person who's paying for care wants to see better outcomes and can see it being done more efficiently, then that's absolutely. They don't always know how, and we're working with that, and it's not an easy next step. But I'll also add just one quick addendum to that. If we put the patient first, sometimes the patient will want that, and they will go back to either their employer or perhaps their state. And an example that I was so struck by 4 years ago now was a group of very big employers, Fortune 500, were talking about what they could be doing, and they were hearing from their employees that they wanted access to midwives and couldn't figure out why midwives were not better access there. So there was the big employer saying, why is the insurance company not allowing this to happen? And so using that force, so as a stakeholder, the big employers can be critical. And I think having patients be able to articulate what they want, that's our job, to make sure they understand what maybe good care is, and then articulate that to whomever it is that's providing that insurance. It could be the federal government if it's Medicare or Medicaid, but it could be the big employers as well.
Okay, so we just have a few minutes left. I am going to ask Dr. McCauley a question, but I'm going to ask her to be very, very, very succinct. It could take a very long answer, I realize that. But then I'm going to ask the entire panel, in summary, this report, the second report on the future of nursing, was about how nurses can achieve health equity. What is the role of nurses in achieving health equity? Okay, so I'm going to ask for your most salient, most important point, and I'm just going to go bing, 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 and that will bring our session to a close. But Dr. McCauley, I'm going to ask you to be very succinct. How can we work together to promote the synergy points between this Future of Nursing report and the primary care report?
So, Sue, I think we need to get serious about teaching social determinants of health to all health providers, and these two reports would be part of the required reading about the complexity of how health professionals can address health equity and access to care. So I think for us to really understand health equity and to really see our role as nurses in promoting health equity, we really have to understand social determinants of health and it be part of our DNA from the beginning of when we began to study in a health professional field. So that's just one idea.
Okay. All right. So that's talking about what can we do to create synergy between the two reports. Okay.
I think both reports, the health equity is a link, a clear link between those two reports. But if we get serious about health equity, it will bring these two reports together.
There you go. All right, Dr. Chen, what is your most important point for this audience in terms of how nurses can address health equity? You can stick on this topic if you want, lifting practice barriers and payment models. What's your most salient point?
When we've taught medical students at the University of Chicago about health equity, we found that paradoxically, if we don't talk about solutions and advocacy, then the students get disillusioned and disempowered. And so you've heard a variety of suggestions over the past hour and a half. I would ask that everyone listening to this webinar ask themselves, where along the spectrum of change, mobilizing change to advance health equity, are you comfortable? Whether it's individual patient care, whether it's just working with your clinic or hospital or organization to do the internal change, whether it's to join Ellen Marie in Washington and, work on legislation and all. Is it like working with organizations to educate and to message about this, to change the public narrative about the importance? So it's even more important for there to be addressing social terms of health and nurses' critical role. Hopefully, over someone's career, people feel comfortable in a variety of different roles, seize the opportunity, a lot of opportunity.
Okay, Dr. Whalen, quickly. You're on mute.
I muted myself instead of unmuting it. I'd say for every nurse listening, they should do two things. First, they should think about the impact they're having on the lives of their patients. Questions they're asking, helping them to think through what's happening, all of that goes to the equity issues. Someone gets a prescription, do they have the refrigerator to put that prescription in? So, and understanding how critical that role of the nurse is to making that happen. But I'd also ask them to think about what policies at their institutions, whether it's a school or a system, health system, a hospital, what policies are there that are getting in the way of you doing a better job? And then be proactive about asking how those policies are made and maybe if there's something that you can do to tweak those policies to do a better job serving the patients that you're doing a great job serving. So I'll stop there.
Great. So speak up. It's all about understanding the issues and speaking up. Don't let somebody get in front of you. Okay, Dr. Rowe, most important point here.
I think we need a communication strategy. One of the problems with studies from the National Academy or other places is that they sit on the shelf. When we had the original study, Professor Julie Fairman from the University of Pennsylvania School of Nursing, and Donna Shalala, who chaired the committee, and I had published an article in the New England Journal of Medicine about the study findings and recommendations, and it got tremendous response. And then people started going out and lecturing and annual meetings of nursing associations, publishing editorials in nursing journals. I think Sue Hassmiller should give a talk at every school of nursing in the United States.
I'm trying.
And and we need and the problem with communication strategies is that they're never in the budget, right? They're never in the initial study budget, and you need to get lucky and have some friend like the Robert Wood Johnson Foundation or AARP to come along and help. But I think we need a communication strategy.
Okay, thank you. Linda, anything you want to add to what you just said earlier about working together and understanding health equity? We got about 30 seconds left here, and I got to get Dr. Lawson in.
Let's get Dr. Lawson's comment.
Let's get the frontline provider in.
Oh my
Dr.
goodness.
Lawson.
No pressure here. So, I'm just going to keep it really simple. To all the frontline workers who are owning their own practices and working, particularly in rural, underprivileged areas, for us, the ability to practice at the fullest scope of our practice will directly affect health equity. Directly. So having that ability to do so here in New Orleans, in Louisiana, would have a great impact on the residents in the communities that I'm seeing.
Thank you. I want to thank our entire panel, give everyone a hand. Absolutely astounding privilege to be able to facilitate this with you. Thanks to the audience for joining us. And we are offering CEUs through the National League for Nursing. This webinar will count towards 0.1 CEU/1 contact hour, and the survey link will be sent in an email following this webinar. The slides from this webinar will be available on the National Academy of Medicine website. I want everyone to get onto the listserv for the future of nursing, where you can access the link. I think the slide is up, and you can complete the quiz and earn your CEUs. The quiz will be available until August 18th, and the attendance verification code also on the slide is 721. Thank you. I hope all 1,600 of you were able to join for this webinar today. Astounding speakers. We will have 2 more webinars this summer that you can register for on the National Academy of Medicine website, one on August 4th on nurse well-being, and August 11th on diversifying the nursing workforce. Bye, and have a wonderful day. Thanks, everyone.
Bye.